Good evening, guys, or good afternoon. Today's discussion B is about ankle replacement surgery and ankle fusions. Okay, so we're going to discuss those for B. So please join me for discussion B. Here we go. Here's a concise summary of the main points from the article Ankle Replacement Surgery: what it is, benefits, risks, and prep and recovery. What is ankle replacement surgery? Also called total ankle arthroplasty, TAA. Replaces damaged or arthritic joint or ankle joints with metal and plastic implant. Aims to relieve pain while preserving joint motion and function. Newer techniques use 3D printed guides to minimize bone removal. Ankle replacement versus ankle fusion. Replacement maintains motion, but implants may wear out over time. Fusion eliminates motion for pain relief, longer lasting, but affects gait. So somebody may walk differently because of ankle replacement surgery. Patient satisfaction is similar to patient satisfaction is similar for both procedures. When is it recommended? Considered when conservative treatments, medication, and physical therapy bracing fail. Traditional for older or less active patients due to implant lifespan, which is 10 to 15 years. Improved design now make it viable for younger, more active individuals. Would you like a comparison chart between ankle replacement and fusion, or a deeper dive into post-op recovery strategies? Here's a clear comparison between ankle replacement and ankle fusion based on the article Ankle Replacement Surgery: what it is, benefits, risks, and prep and recovery. Future ankle replacement, TAA. Ankle fusion: motion preservation, yes. Maintain joint mobility, no. Eliminates motion for pain relief. Now remember, the difference is that ankle replacements preserves motion. Ankle fusion takes that away, folks. Okay, so we have that cleared up. Pain relief effective with improved function. Executive but alters gait. Longevity: implant lasts 10 to 15 years. may wear out, permanent no wear out issues. Gait impact, more natural walking pattern, slower pace, shorter strides. Surgical techniques, uses metal and plastic implants, newer 3D guided tools, bone fused together to prevent movement. That is ankle fusion, guys, for those of you who do not understand. Ankle fusion is where the bones are fused together for pain relief, but the movement goes away. Okay. Patient satisfaction, comparable to fusion, comparable to replacement. Ideal candidates, historically older, less active, now broader range, often chosen for durability and simplicity. Would you like to explore how these options align with different patient profiles, like active aging adults or those with comorbidities? Here's a breakdown of the risks associated with each procedure based on the article. Ankle replacement, total ankle arthroplasty risks. Implant wear and tear. The artificial joint may degrade over time, typically lasting 10 to 15 years. Revision surgery. If the implant fails, additional surgery may be needed. Infection or blood clots. As with any major surgery, these are potential complications. Limited long-term data, especially for younger, more active patients using newer implant designs. Ankle fusion risks, altered gait mechanics. Fusion eliminates joint motion, which can lead to slower walking and shorter strides. Second, guys. Let's see. Okay. Okay. Altered gait mechanics. Fusion eliminates joint motion, which can lead to slower walking and shorter strides. Adjacent joint stress. Increased load on nearby joints may lead to arthritis or discomfort over time. Non-union. In some cases, bones may not fuse properly, requiring further interventions. Permanent loss of motion. While effective for pain relief, it sacrifices flexibility. Would you like to explore how these risks intersect with patient profiles, like those with frailty, cognitive concerns, or high mobility needs? Cognitive considerations play a crucial role in determining the most appropriate surgical options, especially for patients with memory challenges, executive function limitations, or conditions like dementia. Here is a deeper look how cognition intersects with ankle replacement and fusion decisions. Cognitive considerations in surgical choice. Cognitive factor, ankle replacement TAA, ankle fusion. Post-op compliance requires adherence to rehab protocol, weight-bearing restrictions, and follow-up care. Simpler recovery with fewer long-term demands. Rehabilitation complexity involves structured physical therapy to restore motion and function, less intensive rehab focus is on healing and stability. Risk of falls or injury, preserved motion may improve gait, but also requires coordination. And balance. Reduced motion may stabilize gait, but alter biomechanics. Decision-making capacity, informed consent must include understanding of the implant, lifespan, and revision risks. Easier to explain as a permanent solution with fewer variabilities. Okay. Caregiver involvement may require active caregiver support for mobility and rehab. Less demanding post-op care, easier for caregiver to manage. Cognitive decline over time. Okay, implant longevity may outlast cognitive capacity, complicating further revisions. Fusion offers a one-time solution with minimal future interventions. For patients with mild cognitive impairment or early stage dementia, fusion may offer a safer, more predictable path. But those with stable cognition and stronger caregiver support, replacement could preserve mobility and independence longer. Would you like to co-design a decision framework that integrates cognitive screening tools with surgical planning? Here are some real world examples of how cognitive considerations influence surgical decisions, particularly between ankle replacement and fusion. Okay. real world scenarios. Number one, mild cognitive impairment with high mobility goals. Patient profile. A 72-year-old with early stage memory decline, but strong motivation to stay active. Surgical choice, ankle replacement may be considered if there's reliable caregiver to support the patient, can adhere to rehab protocols. Road ratio innate, preserving preserving joint motion, supports independence and gait, but requires constant follow-up through moderate dementia with fall risk. Patient profile. An 80-year-old with moderate dementia and history of falls. Surgical choice. Ankle fusion is often preferred. Okay. Rationate. Simple recovery, fewer post-op demands, and reduce risk of implant complications due to cognitive decline. Cognitively intact but socially isolated. Patient profile. A 68-year-old living alone with no caregiver support. Surgical choice. Fusion may be safer despite cognitive capacity. Okay, rationate. Lack of support may hinder post-op compliance and rehab needed for replacement. 4. Progressive neurological condition. Patient profile. A 65-year-old with Parkinson's or Alzheimer's disease in early stages. Surgical choice. Fusion is often chosen to avoid further revision surgeries. Rationate. Cognitive and motor decline may outpace implant lifespan, complicating future care. These examples highlight the need for interdisciplinary planning, integrating cognitive screening, caregiver assessment, and long-term functional goals. Would you like to co-create a cognitive surgical decision tool tailored for aging populations or memory-friendly care models? Okay, guys, so that is B for you. I may do C later. So I'll pop back on shortly for C, and I will see you guys then. For now, Gator Wellness, take care, folks.